as part of the Miller Center series on election 2024. My name is Vivian Riefberg, and I'm a professor of practice and the David C. Walentis Jefferson Scholars Chair at the Darden School of Business at UVA, and a senior fellow at the Miller Center, where I'm part of the Miller Center's project on health policy. I'm very excited to welcome two very thoughtful colleagues who come to this conversation with policymaking, business operations, and healthcare investing expertise. I'm going to introduce each of them, and then we'll start with one of them as we move through questions. And then I will also direct you for your ability to put questions into our Q&A function for the latter part of this discussion. Our first panelist is Adam Bowler. He's the founder and managing partner of Rubicon. Adam has nearly 20 years of experience in entrepreneurship and innovation in the private sector and the US government. Adam founded 3 successful healthcare companies, including Landmark Health, a company delivering around-the-clock medical care to chronically ill patients. From there, Adam took on major roles in the US government, including being the director of the Center for Medicare and Medicaid Innovation, where he worked on value-based care for the United States. Adam was also a founding member of Operation Warp Speed, unanimously confirmed by the Senate as the first CEO of the International Development Finance Corporation, and a negotiator in the historic Abraham Accords. After his government tenure, Adam started Rubicon because he wanted to build healthcare companies to transform how healthcare is delivered in America, as he saw the power of bringing the private and public sectors together to solve our nation's greatest healthcare challenges. Our second panelist is Dr. Bob Kocher. Many of us do fondly call him Dr. Bob. He is a partner at Venrock and focuses on healthcare IT and services investment. He currently serves on a myriad of boards, including Devoted Health, Virtua Health, Aledade, Lycra, Need, Accompany Health, Candid, and Primera Blue Cross. He's a board observer at Stride, Suki, Smith RX, and the Public Health Company. Additionally, he hangs out in the academic world with some of us as well. He's an adjunct professor at Stanford University of Medicine and a non-resident senior fellow and advisory board member at the Leonard D. Schaefer Center for Health Policy and Economics at USC. He also serves on the advisory board of the National Institute of Healthcare Management. Now, like Adam, Bob has government service as well. Prior to Venrock, Bob served in the Obama administration as Special Assistant to the President for Healthcare and Economic Policy on the National Economic Counselor. He was also a partner at McKinsey & Company, and he is indeed an internal medicine physician. Now, how this is going to work is I'm going to ask a series of questions, and in the last 15 to 20 minutes or so, we're taking questions from the audience. Please put your questions in the Q&A function at the bottom of your screen. In this discussion, I am asking our panelists to put on their policymaking, their management, and their business investing hats. It's terrific that they each have experience that crosses all 3 of these boundaries. So Bob, why don't we get started with you? I'd love to hear from you what you see as the 3 to 4 most important trends in healthcare in the US today and impacting our society. What's important out there?
Well, thanks, Vivian, for hosting us and bringing us together. It's a joy to see you and take part in a fun conversation with you, and I look forward to the questions from our listeners today. I think actually the 3 most important things are first, affordability. Our healthcare is very expensive. We know that America is, sets the benchmark, unfortunately, for the world on what healthcare costs. And it's not only the premiums, but it's the cost sharing. I think finding ways to make healthcare more affordable will help make it a lot more accessible. But that's sort of number 1. Number 2, I believe, is actually access to care. We've done a good job in America of expanding insurance for people. But once you have insurance, when you try to get that care, you will find that there's long waits to see a doctor, whether it's primary care or obstetrics. Specialty care is really hard to get into in the country. And while there's been a bunch of startups doing virtual care and things, like it's hard to actually use your health insurance. And so that's sort of number two. And I think many people believe, and I do too, that if we had better access, things would be caught earlier, people would have like suffer less. It'd be really, really important and good. That's second. The third big thing I think is working on equity in healthcare. No matter where you live and what insurance you have does have more of an effect than you'd expect on like the quality of care that you get. And there's many parts of America, whether it's in rural communities or in lower income parts of cities, where the actual outcomes are super different. And it's just it's an inequitable thing that both you have lower access, you have less likely to have evidence-based care. And there's a big opportunity to actually root out that inequity through using data to figure out which patients are not getting the right treatments, to reroute referrals to the right clinicians. That this is a giant opportunity, and I'm excited to see, like with AI, that's one of the areas where I think will be helpful, is actually looking for like unexplainable differences and trying to like attack those, and also monitor to make sure people are getting better. But I come back to it saying I think the big issues are really cost, access, and quality. And those are maybe timeless, but I think that, we're at a point in time where we can see progress on all those, hopefully.
Terrific. Adam, we've just heard Bob talk about the three things that he thinks are the most important trends. He talked about affordability, about access, and about equity. I'd be curious, when you step back and think about the important trends today in U.S. healthcare and that are impacting our society, are they similar? Are they different from what Bob's saying? And how do you think about it?
I feel like Bob, when we talked about it, I feel like we should like invent a big, like me and you could get into it, like a TIFF. Because the problem, we have to like highlight differences because Bob and I think alike. And listen, it is a very good thing for the most part about the U.S. healthcare system is beyond the politics or the noise. There's a lot more alignment than I think people think, a lot more. And so I think what Bob said is correct. I would say I am excited about so one dynamic that I think will be positive about, so there's a lot of tumult in the Medicare markets now.
And for those in our audience, just a reminder, Medicare is the program that largely takes care of the elderly over 65. There are other special parts of Medicare, but it's primarily a program for our seniors. But continuing, Adam.
Actually, that was a good setup. So now I know that gives me level. I won't go into like active terminology. So I'm keeping it basic. Okay, so there's a lot of tumult in Medicare right now in basically the way government pays health plans. So there's a lot of tumult. And when you think about U.S. healthcare, if I want to be kind of simple about it, you really divide into three areas. As Vivian was mentioning, you have people over 65, the Medicare population, you have poor people, the Medicaid population, and then you have people with jobs, the commercial population. That I'm simplifying a little bit. You have the VA too, so that's your simplification. So sometimes, and what's happened is for a while, Medicare, private Medicare or Medicare Advantage was flying pretty high. And when things fly high, sometimes there's a lot of innovation in them because people say, oh, we can do this, we can do that. So there's been a lot of innovation, I think, on the Medicare side, which even though, and by the way, so everyone knows, healthcare is very cyclical. And so what will happen, you'll see, is Medicare right now is not flying as high as it will. In a few years, it goes up and down. These are waves, right? It's kind of like interest rates. And so now I think what you're going to see is a lot of push toward more innovation for poor people in Medicaid and more innovation in the commercially insured population. And so I think that's kind of a good thing to think about different pressures that pushes you to different things.
Okay, terrific.
Let me make one comment. One interesting thing about Medicare is that it actually tends to be the R&D developer for healthcare policy in America and the early adopter of new things. And Medicare does that in two ways. One, the Innovation Center that Adam ran a few years ago, and in the regular Medicare program itself. And so the leader in America for value-based care and for paying for virtual care and for new models of care tends to be Medicare. And as Adam pointed out, it ebbs and flows, but now you're seeing those things be emulated and adopted and adapted to the commercial segment and to Medicaid, which is a unique feature of our healthcare system. It's unusual for the government to be the R&D leader in this space, but that's certainly true in healthcare, is that Medicare tends to be the inventor of the new things. And there's enough data now to say that value-based care is better, that it is lower total cost and better for quality and better for access, and that thankfully it's being emulated by the rest of the insurance markets.
So in light of government being an innovator, which you're right, you don't always hear that being said. Let's talk a little bit about the healthcare agendas of what could be two different administrations. And I really appreciate that you guys have joined us today, because you've served in one in a Democratic administration, one in a Republican administration. Love to hear what you believe, and maybe Adam, this time I'll start with you. What do you believe will be the healthcare agenda in a Trump administration, and why, were he to win? What's going to be important on the agenda?
I mean, first, I'd like to say that the Republican administration is much better than the Democrat one.
Oh, here we go. Here we go. Bob will get in there, I'm sure.
No, I think that actually, I mean, again, you're going to see shared commonality. I think drug pricing will be a focus. So I think that will be a focus. I can go into some of the history, because even in the prior Trump administration, we learned a lot from what people did in CMS before and built on it in the Obama administration. So I think that will be big. I think price transparency and site neutrality from a payment perspective. And so really, let me give you—
What do you mean by price transparency? If you could just elaborate 100%. On that for our audience.
So actually, yes, I will. On the first one I mentioned, drug pricing, let me just be specific, which is, this is the easiest way to describe it because all Americans understand this, is why is Germany paying a third of the cost for the same drug as the United States? Okay. And that doesn't always apply, but why? And if you look at pharma companies' EBITDA margins, where they're making money, if you actually look at their EBITDA margins, they're not that crazy, right? They're not generating like 40% EBITDA margins as companies, but some are, but many of them aren't. But the share that comes from the United States is much higher.
Yes.
And that is something that the Biden administration has focused on through enabling the federal government to start negotiating prices of high-cost drugs. And I think that the Trump administration approach may be slightly different. It may achieve the same end, which is, when I was there, I worked on something called the International Pricing Index, which is basically looking at developed countries and saying the United States shouldn't be a crazy outlier here.
That we would have a reference point, you're saying, of some kind of international reference point.
Yes. And actually, my thought process from a drug company perspective is a lot of other countries negotiate prices. And so if it bleeds in over time, if our pricing was here and developed countries' pricing was here, what you would see over time is this. So I would think about it a little bit akin to a trade deal. You know, the second one that I mentioned, pricing transparency and site neutrality. So what that means is, if you look at the way that hospitals and health plans price things, it's extremely opaque. At the end of the day, if you called a hospital now and said, how much is XYZ? They cannot answer that question. And one of the thoughts is, when you think about opaque things, when they're opaque, why are they opaque? And maybe like what the CIA does needs to be opaque, but pricing for healthcare does not need to be opaque. And opacity, is that a word?
Yes.
Yeah.
Wow, I've never said that word before. Opacity. Opacity leads to not good things oftentimes. So one of it is just shining a light on something that is opaque that every American should be able to see. And then the second thing, I said neutral payments. So right now, if you get a procedure in a hospital versus in a physician office or like let's say an ambulatory surgery center, the hospital is paid a lot more.
Right.
Now, some of that is because of different regulations they have to follow. And, if you ever build a hospital or deal with it, like they have to deal with a lot of shit, in fairness, OSHA and all these other things. But sometimes that pricing is much higher. I think that's probably, I believe that is a problem. And I think that the more you can establish a free market where pricing is somewhat normalized, the better, as long as, and I want to be clear in all cases on this, as long as the patient's protected.
Yes.
And so there are obviously some procedures, maybe it's not time to do open heart surgery in a doctor's office, just to be specific. So, and that's part of the federal government's job and always will be to ensure actual safety precautions. So I think that's two examples of some focus areas.
Things that would be on the minds. Bob, what about in a Harris administration? What do you think are the kinds of items on a healthcare agenda in the Harris administration? Would you expect to see?
I think we're going to see her be very interested in trying to improve access to care for moms and kids. So part of her agenda is really been thinking about, protecting access to care for women, to ensure contraceptive rights, abortion access. And I think you can extend that further into then what you would do to support moms after they have the kids. And so in the Obama administration, we made a lot of progress on extending coverage to most Americans through the Affordable Care Act for working adults, and then in Medicare, expanding a lot of the programs in Medicare. But the area that we didn't focus as much on is moms and kids. Right now, when a mom has a child, she and the child can stay on Medicaid for the first year. I think you'll see her try to extend that period maybe up to age 6 or up to school age as a way to ensure that the children get all the vaccinations, that they get the good pediatric care. There's good evidence to suggest that coverage for kids leads to lower special education costs when they go to school. And also, if you cover moms, you'll also have hopefully, better environments for the kids to develop. Related to that, I think you'll see her propose tax credits for daycare, so moms can go back to work and afford childcare. In a lot of the country, you can't either find it or afford it. So I think you'll see both tax credits from moms to pay for daycare and then money to support the creation of more daycares, maybe in exchange for accepting moms who have the tax credits to use them. And that actually is a cost-effective policy because if moms go back to work, they pay payroll taxes, they're covered by employer-sponsored insurance, the Medicaid rates go down. And so it's one that economically should be a positive program and probably very affordable for the government to do. On traditional Medicare, I think you'll see them continue to do the Inflation Reduction Act programs. So more drugs.
What does that mean?
So President Biden passed a big bill called the Inflation Reduction Act. It had a lot of stuff in it, had some healthcare stuff in it. The healthcare stuff in that bill was drug negotiations. So Medicare, for the first time, negotiated prices on 10 medications, and that legislation calls for them to do more of that. And I think you'll end up at prices similar to what Adam would also achieve in reference pricing. I think you'll get to the same place. That bill extended subsidies or gave extra subsidy for people to buy insurance in the individual market in the Obamacare or ACA exchanges, and that pulled people into that market. Those subsidies are set to expire. They were temporary. So I think you'll see her try to extend those subsidies and keep more people insured. That's probably 500,000 to 2 million people, depending on the estimates you read, of people who gained coverage through that program, through the extra subsidies, and so try to keep them.
So Adam, do you think that subsidies will be an issue in a Trump administration, that they will continue, or how do you think that unfolds?
So I think during the debate, the president specifically mentioned his plan for that. But sorry, I'm kidding. Let me start out just.
Yeah, I certainly do remember, but I'm being respectful of all. That's what we do at the Miller Center. We respect views.
Just one thing on the moms and kids, because the biggest concern we have with the Harris plan is excluding dads. We're going to do moms and kids and dads. And
what does that mean? No, seriously, when you say excluding dads, I mean, what do you want to do things that, preserve the subsidies, for example?
I'll go to the subsidies.
By the way, are not just for moms.
Sorry, I'll stop joking around. So on the subsidy side, I think there may be a really interesting opportunity. And the reason I say it is anytime, because it requires action to continue it, right?
Correct.
And anytime you have that opportunity, it creates a moment for change. And I think it's important when you're in the federal government, Bob knows this, is you don't want to squander the moment. And so what I hope and what I think is there are a bunch of things that we can do to the ACA in setup, to make the AC better. Not, which is normal, by the way. You have got this is our first shot and great. And, it's set up mark. So it's actually not a criticism. It's a building. It's a building it back better. So I'll give an example. I do think there's been some products in the market. United actually sells one that provides really good incentives for consumers at the time of a need from, let's say you have a surgery, to go to very high quality, low cost providers. And by the way, it's not utilization management. It doesn't stop anybody. It actually provides a positive if they want to go. Right. And consumers at the point of need 90% choose because they get money back. So one interesting compromise here could be how we set up ACA in a way that's actually consumer friendly and reduces costs enough to more than pay for the subsidies. Now, what I just made something that's super complex and not proven sound really easy, so it's not. But I do think those kind of things could come together and be really interesting because there's a legislative moment.
Got it.
I think, I think for Democrats, because there's going to be right now, the government's funded to December 20th. And you're going to see, no matter who wins, the government keep having to do these compromises to fund the government or it shuts down. And I think you're going to see Democrats make as one of their sort of prerequisites for the funding bills to, also have money for defense and other priorities, that you're going to stick ACA subsidy extension into these bills. So I think you're going to see them extended on a piecemeal way, probably for a while. I think the time it gets fixed, if it gets fixed, there's also going to have to be in the next 2 years a big tax bill. Many of the Trump tax cuts expire. And no matter who wins, you won't want them all to expire. There's some they're going to want to extend. And so you're going to see also a big deal made around the extension of those and probably coupling money for foreign policy initiatives that we have and other things all put into these sort of big bills. Back to Adam's comment, you don't want to miss the chance when action has to happen. And so you'll see ACA subsidies get, I think, rolled into those.
Terrific. And on value-based payment and value-based care, I'm hearing both of you use some of that language and some of that activity. Is that an area where you think there's actually quite a bit of overlap and agreement? Or are there some big differences that I'm not picking up on, if you will?
This is one where the Trump administration, I think, did a great job. So Adam and his colleague, Seema Verma, who ran Medicare, did a wonderful job of creating more value-based payment programs, which reward clinicians for care that's higher quality and lower cost. And one of the flaws in the programs that we initiated when we did the Affordable Care Act is we didn't have upfront payments for clinicians. And so funding the work to do the programs well was hard to do. And so they created some upfront payment versions of these programs. They rewrote many of them in kind of a 2.0 version, building on the first versions. They created specialty care programs, and it's an area where I think there's complete consensus that this is a better way to pay for healthcare. And we want to have more healthcare kind of flow through these models. In the Medicare Advantage program, which is the private version of Medicare done by commercial insurance companies, there's a lot of innovation there too on models of care that are less based upon in-person visits and more based upon engaging you throughout your care. And you need payment models that aren't fee for service to do that kind of care. And so I think you'll see lots of efforts to extend those models. And actually, it's an area where I think there's a lot of overlap in both ideas and imagination.
Terrific. Adam, do you share that confidence that there'll be more, not necessarily collaboration, but certainly more overlap on this idea of value-based payment and a continuation and a growth in that arena that people can expect, whether it's a Trump or a Harris administration?
I do. And I think one of the learnings, and this is for everybody, I think, is, again, what you see on TV, what you see people say. Not everything is as partisan as it seems. And I don't just mean healthcare. And I think that one of the things I noticed working in Washington is the noise was quietest when I was working in Washington.
I smile as someone who lives inside the Beltway and spends time in Charlottesville and more broadly with UVA. But I share your view, Adam, that there's a lot of good dialogue and good thinking that goes on. It's just quieter in those environments. Indeed, I met you when you came to Washington during that period. So I do appreciate that. Maybe if we could turn to Medicare and dig a little deeper. One of the big changes that has occurred in my professional lifetime, if you will, is how we went from fee-for-service Medicare to being the major part of the program and Medicare Advantage to being the minor part of the program, to now we're crossing over into a place where more and more people are on Medicare Advantage. And that does seem to be the world of the future. What do you see unfolding there? If you say this is part of our innovation engine, what are the kinds of things you see happening there, in particular with Medicare Advantage? And I'll take either one of you to dive in on this one as you like, but I'd love to hear. I know, Adam, you spend a lot of time thinking about this. Could you maybe start us?
Sure. I think under either administration, Medicare Advantage will continue to grow. I do think that the growth rate may be different. And so it's interesting the way that it works. So what happens is, the way to think of it is this, which is if CMS, who runs Medicare and Medicaid, decides to cut Medicaid or Medicare Advantage rates, right? So they come out and they say, okay, rates are going to look like this, it's not as high as people expect.
Right.
Then what happens is you have an existing book of people, and then it takes a while to price in and change on that basis. And it's not like, in certain cases, right, the market's going to be able to respond immediately. You can't respond immediately because people signed up for the insurance. And so oftentimes what happens is it's maybe there's some analog in like the way that the way that oil prices change, but it doesn't matter at the pump per se. It just sometimes it matters a little bit, but not a lot. And so this matters for a while. So if what happens is if CMS cuts Medicare Advantage rates, it takes a while for the plans to respond. and come out with new products based on that. So they lose money until that happens and it reprices. And then in theory, you reach somewhat of an equilibrium at a margin level. Now, during that period of time, they would lose money, but then they reach equilibrium. If pricing increases and it's not expected, the market eventually works. What happens is so price decreases, how do they lower? They take away benefits, right? So right now, there are some plans where if you sign up, you get a $200 card that you can spend on, at the drugstore, et cetera. So what will happen is, they cut, now it's going to be $100 card, or now it's going to be no card, or something like that. Or we're gonna start, maybe you got vision and dental with it. Now you're gonna have a little copay on vision, right? So that's what happens. Benefits change. There's pricing. Now, if they raise prices, what will happen is for a while, they'll make more money. And they'll add, but then everyone will compete and add benefits. And then it will normalize. So that's why I said it works in cycles. And so what really changes in the short term, the money they make changes, but in theory, it should be roughly the same because they don't make great margins no matter what eventually, but there's a lot of volume. But really what changes is the growth rate. If you cut it, then what happens is benefits go down. And when someone is choosing Medicare or Medicare Advantage, they're going to look at the cost and the benefit. Yes. So that's, and I would say different, or I would say you likely, and this is historically, although it changes, it's funny, like when President Biden took office initially, raised Medicare Advantage rates much more than was expected. So you don't know it's traditional all the time, but I would say what has happened, not just rate wise, but a few other things, is toward the end of the Biden administration here, rates were cut much more than what Medicare Advantage expected or wanted. And so you're going through a retrenchment. I don't know what Harris would do. She continues to cut rates. Maybe she'd up it one way or the other. I would guess on the Republican side, you'd see more positive pressure from a rate perspective and some relief.
Bob, what do you think? And not just from a what I'll call political position, but are there other things happening in the Medicare Advantage world that we should all appreciate?
First, I think I agree with Adam. Medicare Advantage will grow no matter what. It's a better deal for seniors at the end of the day. Traditional Medicare is actually expensive. You have to buy supplemental insurance. You have cost sharing. It gives you a great choice, but it's not cheap. Medicare Advantage is lower cost, period, in every market than traditional Medicare. And in some markets, it's free. Like you have $0 premiums, and it includes drugs. And almost all Medicare Advantage plans include dental and vision. And so it's a program that, as a Democrat, I would say is really, really progressive. It's affordable for lower income seniors. And there's a bunch of advantage to that. And so it will grow. I think Adam is probably right that under a Republican administration, historically, they've been more generous on the rate increases. And so, and that's been good for poor people. They've gotten more supplemental benefits. In the last round, the Biden administration cut these benefits because they were probably getting to the point where they were like too generous. And so you're going to see them adjust over the next 2 years. And so you might have a little bit lower growth in that period, but it's going to keep growing. Beyond that, I think you're going to see some real desire by both sides, actually, to think about how to make the risk adjustment system work better. Mm-hmm. A really important feature of Medicare Advantage is you want to make sure that sick people get access to care and that the private insurance companies doing Medicare Advantage want them to be in their plans. The last thing you want is a plan that sort of has an incentive to not give all the treatments needed for an old person. And so the government has a very carefully designed system to pay them a lot more money for sicker patients. And so interestingly, the most profitable patients for a health plan are the old sick ones. And as a Democrat, I love that. I love that we're giving more money to the frail, vulnerable, low-income seniors. Like, that's good.
Right.
The problem is that there's a lot of judgment in sort of how sick somebody is. So as a doctor, when I see you, I can write down that your condition is like bad or terrible. I can make it seem more limiting to your daily life than maybe it is. I can do more screenings and find more stuff, but they may not be things that actually matter. And so there's a bunch of sort of like subjective.
Well, put it positively, a gray zone.
Yeah, and And when you're a Medicare Advantage health plan or provider, you get paid more money for every diagnosis you find. So you find a bunch of stuff. The government went through and said, let's try to fix this some. And so they got rid of some of the codes that doctors would use to document things that patients have, to try to make it more even between how payments are happening between regular Medicare and Medicare Advantage. But so much time, effort, innovations going into this thing called risk adjustment that I think there's a desire to have a better system. And so one can imagine that you could come up with a new model that relies more on laboratory values, the medicines patients are taking, maybe patient-reported outcomes. And so I think you'll see R&D done in ways to make risk adjustment better. Another idea is to take it out of the hands of the doctors and the health plan. So have a third party just do a sampling and then come up with scores. But you'll see a bunch of work, I think, to make that system better, because right now, if you talk to doctors, they'll say, oh my goodness, I'm spending so much time like writing down and coding, and it's not helpful to patients. In some cases, you send people to people's homes to do, basically to do a once-a-year visit and basically write down all the codes. And it's not awesome for patients to have a doctor that's not their doctor doing this work. And so I think you'll see work on coding. I think you'll see work on network adequacy around things like mental health. We know in America, we have a lot of people who would benefit from better access to care for behavioral health. And there's requirements.
Indeed, this is a week and a day associated with mental health in this country.
And health plans have to have networks that meet the definition of adequacy, but they don't actually have to have appointments. And so you think you'll see efforts to have those networks be more accessible and better. And I think you'll see efforts also on the Medicare program to think through how to get more specialists to take part in these value-based care contracts that Adam and I talked about. Primary care doctors, benefit in them and like them and have really adopted them, but it's been harder to get them into specialty models. There's some great models for kidney care and some for cancer, but like things like cardiology and orthopedics, which are big cost centers, coming up with models for those. I think you'll see both sides work on that.
So I'm very struck in this conversation how neither of you really put forward, we're going to see some big legislation, some massive change in what we're doing. And quite frankly, there are many people who say that there will be very little legislation passed, no matter who is elected next. And that health policy will be most impacted by the actions you're describing, as well as, in the courts. And that's particularly due to the rollback of the Chevron Doctrine, which for 40 years gave significant deference to agencies' interpretations, of legislative meaning. I'm curious how you see, if you see the Chevron Doctrine playing out in healthcare and the change from that. It's very early days, as we know, but this is expected to unfold. Adam, Bob, thoughts on this? Have you guys heard much about this? Are you hearing threats on this? Or is it quiet out there?
Bye, Bob.
Well, there's Chevron decision, and there's also one called Wilper-Bright, which changed sort of the statute of limitations for when you can bring a case where the government's causing harm to your business. I think both of them together mean that you'll see a lot of things sort of relitigated, I guess, in the courts. Areas that I'm particularly worried about are the FDA today regulates tests that hospitals develop and market. And there's a whole lot of these that we get in our daily lives. And it's unclear that they actually have explicit authority to do this. Another area is under HIPAA, some of the rules around kind of digital data that's not in the initial law could be challenged for and you can imagine there's people that don't want to have data exchange. You could challenge some of those things. I think you'll see, more efforts to look at, like in the ACA, there's a lot of sections where we say the secretary shall, and then it says, rely on the National Academy of Medicine, the recommendations for what's preventative care and what should be covered. And so I think you'll see more challenges to lots of things that we thought were established, and that's going to be interesting to see how how this flows through the court systems and how much things get stopped. But I think I think litigation and the judicial system is going to be a big part of what happens over the next few years as we'll explore the new boundaries for what's permissible. There's been a lot of challenges to the drug negotiations that Medicare has been doing under the IRA. So far, they haven't stopped it, but there's I think you're going to see a bunch of this sort of going on in the background. I agree with you that there won't be big legislation passed in healthcare. I don't expect some big new law. That's why Kamala Harris is talking about things that are relatively small and not expensive around expanded coverage to young families, maybe moms and dads. But when kids, daycare tax credits fits into a bigger tax bill. It doesn't cost very much. I don't think you'll see standalone legislation that changes Medicare and Medicaid in a big way because it's really hard to do. Takes almost all your popularity. You need a president who cares deeply about doing it, and it crowds out other stuff. And I just don't think that Kamala Harris or President Trump have healthcare as the thing that they're going to want to spend the next, the first 100 days on.
Adam, do you see it the same way? No big legislation, and we're back in the regulatory and court world, and the healthcare lawyers will be busy.
Yeah, I mean, it depends. I think what you're talking about is major changes versus. There could be clarifying legislation, there could be ACA, but taking the meaning of your question, which I think is a significant new thing. No, I don't think there'll be a significant new thing, not in the next 4 years.
Maybe in one area where there could be interesting new things is PBMs. So I think Democrats and Republicans have strong alignment that the PBM role in our healthcare system is one that's sort of out of control. It's astonishing that about half of the price of a drug is being captured by the distributor, the PBM system. And so when we talk about drug prices in America being much higher than Germany or every other country, and we say that they're like 50, 60% higher, interestingly, the drug company is not getting all the money.
They're not getting 100% of that.
They're getting about half of the price. And there's no other thing that's distributed in the world where the distribution system takes half of the money. And the PBMs do it in a myriad of fees. It's totally, to use Adam's new word, opacity, like in the most opaque way you can possibly do it. And it's really harmful to both patients who are sick, who pay a lot more for the drugs, to the small employers who are really paying high prices for drugs. And it's going to like people that don't do much. And so I think you could see actions there to change the rules. The Trump administration proposed, eliminating rebates. And I don't think anybody thinks rebates are a good idea. And so that's a spot where there might be something that happens. But that's not like fundamental change in healthcare. No. But it's an area where there could be change.
Okay, so you brought back up the drug piece, and I'll just remind our audience that I'm happy to take questions in the Q&A function on the system. And we have some questions from the audience. And one of them has to do with the amount of drug advertising that we see, that this is, a country that does allow prescription drug pricing to consumers. Not every country, most countries don't have this. And I'm just curious, do you think this is a big area of cost and is a big deal? And will we see any attempt to change that? Or is that kind of a sidebar to this distribution point you raised about the costs of a PBM and a drug distribution system that we have today?
I have two thoughts on it. One, I don't think it's a significant driver in costs in a significant way. So I don't, I'm not, and I don't want to, I don't know what they spend, but, you're talking about scales of money that it probably not, right? It could be like $50 billion a year by the scope of drug spend. That's not a lot. So it's not, minimize it. I think the question is there too much and how is it spent? The positive of some advertising or the ability to reach consumers, because I'm sure they spend some on TV and stuff like that, but who watches TV normally anyway?
Screen TV today, but go ahead.
This is TV? Sort of, I don't know.
Yeah.
Are we airing this? I guess a little bit. Just some, it's closed circuit TV. So I don't know how much cost, but and I think you could always, one could say it's too much, it's too much. The positive of some advertising that I like sometimes in a way is it does take a message to consumers. And maybe it's, maybe it's because I grew up with a physician and I love docs. I don't love a world where, you know, consumers aren't participants or in their own healthcare. I think that's a mistake. I think people, like in anything, if I hire a lawyer, that's somebody that advises me. But ultimately, I think you want to be responsible for your own healthcare and listen to expert advice, right? You know, when the dean of Harvard and MIT and them went in front of Congress and said didn't make the comment of genocide, I don't know. It was obvious they'd been trained by a lawyer not to say what they said. They didn't all say the same thing for a reason. You know, they said the same thing because they'd been prepped, right? Of course, you're going to go in front of Congress and you get prepped, and they got all prepped, and then they said their canned answers. And the hardest thing on that is you need to decide where to listen and where not to, right? That's the job. So I sorry, I don't know how I got a drug advertising to that. Excuse me. It's too much analogy. But so I do sometimes like that aspect because it does sometimes jog. And sometimes you see something and you bring it to your physician. I've done it, and they're like, oh yeah, I could think about that. And then you have a discussion versus always being reactive.
Any additional thoughts on the drug advertising question?
Well, first, as a doctor, I think Adam's right. Sometimes patients do bring to your attention things to think about and talk about with them that you may not have if they hadn't been prompted by an advertisement. When I was in the administration, we looked at actually regulating, Adam will be like, of course, drug advertising. And it turns out it's really hard because there's two sort of constitutional problems with the government intervening here. One is free speech. And advertising is a form of free speech, and there's not a lot of ways you can curtail it as the government. Number two is Commerce Clause. You're allowed to sell your product, and advertising is a acceptable way to sell your product, and then it's in private sector. Like these drug ads are really not, they're to all patients. They're not just the government, funded programs. And so I think it's really hard actually for the government to have limitations on the ability for companies to advertise their products, whether it's a drug or anything else. The only place the government can really do work here is around making sure the advertisements are accurate and fair and not misrepresenting. And that's why at the end of every ad, there's like the words you can't understand.
And they say it very fast to get through.
Yeah, you might die if you take this drug part. But I don't think you're going to see any changes. Adam's guess was remarkably accurate. $65 billion a year of ad spend. It's also the only growing area of ad spend. So it's pretty important to the media industry that the Democrats also tend to like. And so I think you're going to see nothing happen here. I don't think it actually is that important from a healthcare cost thing. And I think, you can make your own choices whether or not you're persuaded by them.
Got it. All right. I want to turn to investing now. We've had some questions on this as well. What are you most excited about? You guys are both doing healthcare investing. And I think it's just for our audience, I think your careers have been just very interesting. Whether you have an MD, whether you have an MBA, whether you've been an entrepreneur, the two of you have had not only admirable, but very interesting careers. So now you're sitting in the investing world. What are the areas of growth you see that you say, this is what excites me today?
One, I should clarify, I don't have an MBA.
No, you have all you need, Adam. Go for it.
I didn't want, it's tough for me on the MBA. I'm not always convinced of the value. Sorry.
I know.
I'm kidding.
As all of you know, I have one and I teach it. Adam recruits from the MBA schools. So we know he likes them.
Wait, is that who I'm speaking with? Shit. Okay, so I think, it's quite frankly, it's going to thematically fit what I said in terms of what I'm excited about in the future. One of the things that I find, and it's an important tenet for me in investing. So in healthcare investing, we say we only invest in value-based care. So what does that really mean? Because it can mean a lot of things. I will not do an investment that I will not do an investment that doesn't have a positive impact on healthcare. And what I mean by that is cost, quality. It could be efficient. It could be making things quicker. I'm okay with any of that. Here's what I won't do. I won't do an arbitrage business that's just rolling things up. And so why not? Well, one, I don't find it that interesting. Two, I think creating sustainable value is about creating businesses that do well. And I think that when I advocate for things, even on this, where we talk now, I don't want to advocate things just because that I don't believe in, because I just invested in them, right? So I'm not going to. I don't want to say, So I'm not a. I do best if I'm selling concepts, if I'm doing something, when I believe in what I'm doing. I'm not that good of an actor. In fact, I'm not a good actor at all. What I sort of oriented toward, I think specialty areas, like Bob said, in Medicare are interesting because they're early. And I think the early models are showing really good promise. Nephrology being a good one because it's something like 60% of nephrologists or something like that are in value-based care, which is like a huge sea change.
I was going to say that's unusual, as we know.
And again, a great example of bipartisan. I mean, this was something that was discussed, and look, oncology started under Patrick, carried forward. So these are bipartisan things. I think that, and so cardiology. I do like innovation in Medicaid, and then I really want to think about how you can reduce costs and improve quality in commercial. The other thing I would note that we think a lot about are broad trends that improve things. So I said value-based care, and so when we first look at this investment, people said, "Why did you do investment here?" We have focused a lot also on a shift from a research perspective, from only academic to community, which is happening, which is still even early in happening, and which creates a really positive impact. Right? Bob was talking about inequality in healthcare. I mean, I don't think it's a partisan view in any way for me or anybody to say that healthcare is not equal everywhere. I mean, it's obvious. And a great example is if you don't live by an academic center, it's hard to get on a trial.
Right.
And that's too bad. People want them. So that's an example of it. We made an investment in an area. On the Medicaid side, an example is we focused on complex kids, because if it's hard to pay a physician to take care of an older person in the middle of the night so they don't go to the hospital, it's really hard in Medicaid for kids. They get home visit, you get like $40. No one's doing them. But if you do it well, then you can have kids stay home when they don't need to go to the hospital. And if you have a kid that's on a ventilator or IV and you're going to the hospital, I mean, there's nothing worse, right? Nothing.
Right. I say this as a mom. My children are now older, but I appreciate Adam exactly what you're saying. So you're excited about those areas, Bob. Similarities, differences. What's exciting you today?
Well, I think Adam's smart, so I agree with everything he says on this topic. But I would add a couple. I mean,
and I wanted to know our audience to know I knew these guys knew each other, but whether they would agree or not was not totally clear. Go ahead.
I'm sitting in Palo Alto, so I'm sitting in Silicon Valley, and I can't describe how much activity is going on in AI in a way that's like accurate. Like I'm being inundated with people doing AI tools for things, and our firm, which invests in tech and healthcare, like we're making a bunch of investments in AI, and so AI. I mean, AI is like mobile phones and the internet. It's a technology that we all probably are already using, and you'll be using like all the time. And so you're going to see a bunch of, I think, good companies created in every different industry vertical in AI. But in healthcare, I think you're going to see kind of two categories: AI that does administrative costs or administrative things, and healthcare is the area that probably does the most e-faxing of any industry in the world. And so you'll see a bunch of AI to get rid of a bunch of the paperwork exchanging between insurance companies and doctors and patients and insurance companies and things. I have medical licenses in a bunch of states. And every 2 years, I have to like submit like copies of my medical education classes and proof of my
This should all be
insurance.
eliminated,
I mean,
easy.
this could be the stuff that computers can do.
Right.
Every day, every doctor is doing prior authorization requests or asking insurance to cover stuff.
Right.
And
So
it's
all the administration you see getting attacked. What about clinical care?
on clinical, I think you're going to see like a question patients always ask me is, when should I feel better? Or how do I know I'm getting better? And we kind of make it up. I think you're going to have AI do remote monitoring or ask patients how you're doing and be tracking trajectories of improvement to make sure we're giving you the right medicine and things are going well. We have the concept of remote monitoring, but it's kind of clunky today. AI is going to make that a lot better. I used to be, before I got sidetracked at an oncologist, Dana-Farber, and we would try to interpret genetics and look at the data and try to figure it out. AI is going to be a lot better than that. Drug dosing and drug choice is going to help a bunch. So it's going to really improve care a lot. Another area is PBMs. These big PBMs that I talked about a while ago as being sort of, bloated and not efficient. I think you'll see new versions of that are much lower cost and get medicines a lot more cheaply.
And will we have job loss in healthcare? Healthcare has been one of the biggest continued growth in jobs and opportunity. Is AI coming for the jobs in healthcare or not?
I think some of the admin jobs for sure, and that's going to make healthcare more affordable. I mean, the reason healthcare costs so much is that it has a lot of people in it. So I would tweet out every quarter the new jobs, and healthcare is the one sector that every quarter hires more people than every other sector in America. And so it's so expensive, not because of the drugs and not even because of the PBMs, but because of all the workers. And so I think you're going to see, and the ratio of clinical worker to admin worker, actually, there's more administrators than clinicians in healthcare in America. So I think you'll see that part shrink. And I think that's probably a good thing and will be better experience for everybody, actually, to have that happen. I don't think you're going to see clinicians see their jobs threatened by AI in my lifetime, honestly.
So that it's more like a complementary thing to the clinician rather than a complete displacement of the physician.
And other areas, I think value-based specialty care, Vivian, is a really exciting area. I think micro hospitals that are lower cost are an exciting area. So there's a bunch of stuff. I think we're in a tailwind of good investments to be made in healthcare.
Okay, I want to close with one final question. The largest health insurance program in the country in aggregate, is the Medicaid program. You add up all the states. And in this last period of time, from the passage of the ACA to the present, more people have been covered by health insurance and many by Medicaid. When you step back, do you see the continued, we've had a certification going on across the country, and that's been had to take place over the last many months. But do you see Medicaid continuing to be, a very large and growing program? And what do you think happens in the states on this? And then we'll probably have to wrap it up. So it's going to be like a speed dating answer. Growing, yes. Something big happening. What do you think?
Well, under a Trump America, there will be no more poor people. So we're good.
Okay. On that note, Bob, anything you'd like to close with?
It's going to continue to be a super large program, and you'll have a lot of state experimentation no matter who wins.
Okay. Gentlemen, it's been my pleasure to be with you. It's been a lot of fun. I appreciate the good collaboration and the insights that you bring. And next time I'm going to have you in Charlottesville and getting together face to face with our students. But I thank everyone for being here. This will also be available online for those who want to revisit something or send it on to your colleagues and friends. And we hope that everybody has, if you're in Florida, that you're safe and that your power is getting restored and that you get the help and services you need and that everyone has a good rest of your day. And thanks again, Adam. Thanks again, Dr. Bob. And I'll look forward to seeing you both in person soon. Take good care.
Thanks, guys.
Thank you.